Good afternoon, everyone. I'm Dr. Demetrios Tavares. I'm last few days as a clinical advisor to CCO's PATH reporting project, which is coming to a close after a successful and complete implementation in the province of Ontario. So I'm Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists. I'd like to welcome everyone to today's educational session on the CAP checklist for duct carcinoma in situ of the breast. Before I introduce our speaker and we get formally underway, I'd like to take care of a few housekeeping items first. The presentation will be approximately 90 minutes in length and will include approximately 60 minutes of presentation time to be followed by 30 minutes of question and answer. This is being recorded and will be made available to all participants via email links once the following recording becomes available. The presentation and the recorded presentation are eligible for CME credits upon the completion and submission of evaluation forms available electronically. The information for accessing the evaluation form was provided in the notice for this session previously distributed. Please note that the CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. The sessions will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. Please refer to the session notice for the exact deadline date. Note that everyone's line has been automatically muted for today's presentation. Due to the number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If having difficulties accessing the WebEx portion of this teleconference, please call the WebEx support line at 1-866-293-3239. I'll just repeat that number again, 1-866-293-3239. I invite you to submit questions at any time during the presentation using the chat feature. For instructions on how to use the WebEx chat window, please refer to the document previously distributed. During the answer portion of the presentation, in order to avoid question collisions, I will post submitted questions on your behalf as long as time permits and in the order in which they appear. In the window, please include the following information: your institution's name, name of the individual posing the question, and your question. It is my distinct pleasure to introduce to you Dr. Penny Barnes. Penny obtained her MD degree at Memorial University at Newfoundland in 1988 and took a rotating internship followed by a year of internal medicine at the University of Western Ontario from 1988 to 1990. Following training in anatomical pathology at Dalhousie University between 1991 and 1995, and Royal College Fellowship in Anatomical Pathology, became staff pathologist at Camp Hill Medical Center and assistant professor of pathology at Dalhousie University. In 1999, she took subspecialty training in breast pathology at Nottingham University in the Nottingham National Breast Screening Training Center, England. On her return to the Queen Elizabeth II Health Sciences Center, she became primary regional subspecialist in breast pathology and to Dalhousie's Faculty of Medicine, where she is the Associate Professor of Pathology. Barnes is an invited member of two Health Canada Canadian Breast Cancer Initiatives, the Prepare National Breast Cancer Guidelines, and the Key to Improve Quality and Uniformity from Breast Cancer Screening Program. There are many scientific presentations and publications in her areas of expertise. So I now hand you over to Dr. Penny Barnes.
Thank you very much, and good afternoon, everyone. Today's topic is the College of American Pathologists protocol for the examination of specimens with DCIS. Oops, and I can't advance my slides, Sarah. Interest. And objectives today are to review the CAP protocol for the examination of specimens for patients with DCIS of the breast, and to review the cancer case checklist for DCIS. The protocol was first published in January of 2009 in the Archives of Pathology and Laboratory Medicine. And we'll just review this again. So we're instructed to submit questions via the chat line, including your institution's name and finally the question. So just to begin with the definition, ductal carcinoma in situ is a neoplastic epithelial proliferation confined to the ductal lobular system, entered by the basement membrane layer and myoepithelium. So here, where we have a single duct cross-section of high-grade DCIS, the neoplastic cells are confined to the duct space. And in contrast, this shows the presence of DCIS, but with microinvasive carcinoma, with tumor cells which have now spread beyond the duct into the adjacent stroma. So theoretically, the tumor cells can gain access to vascular channels with potential to metastasize. Again, also with review of basic breast anatomy, there are approximately 15 to 20 large ducts which originate in the nipple, and as we spread more distally, the ducts continue to branch, being in the terminal duct lobular units. Now, these individual ducts are not separated from one another by stroma or in any kind of segmental distribution. Rather, the ducts from each system intermingle with one another. So a surgeon does a segmental resection. One unit is not removed, but rather ducts from multiple duct segments might be included in that. Just to show you an even simpler diagram, the duct begins as the collecting duct at the nipple, expands into the lactiferous and into segmental ducts, where it continues to continuously divide, terminating in the terminal duct lobular units. It's thought that most cases of ductal carcinoma in situ arise in the terminal ducts, where the plastic cells can spread further proximally along the duct and distally into the lobules. Protocol deals with a number of variables that are which we generally report, and the pathologist should be in communication with the clinicians who use our reports to make sure that all the clinically important variables are included in our checklist. So I'll deal with these in turn. The first deals with variables pertaining to specimen type. Then there are prognostic and histopathologic variables pertaining to DCIS. The checklist then deals with treatment effects, lymph node assessment, pathologic staging, ancillary studies, reporting of microcalcifications, and pertinent clinical history. Instructed not to use this checklist for a few specimens. The first are very small incisional biopsies or core biopsies. The second instance is if we have an excision which contains just DCIS, but the preceding core biopsy had invasive or microinvasive carcinoma, we're to use the protocol for invasive carcinoma in this setting and incorporate the previous core biopsy information into that report. As well, we shouldn't be using the synoptic checklist or protocol for re-excisions or completion mastectomies. If find cancer of a higher T stage, so an invasive carcinoma in the mastectomy or excision, then we should use the protocol for invasive carcinoma. If ever we find a greater extent of DCIS in the breast re-excision or completion mastectomy, then we can go ahead and use the protocol. To begin with breast specimens, our tick boxes include variations of partial breast excisions versus total breast excisions. Other would be, I can't think of many things, perhaps a nipple excision for Paget disease. The majority of cases that we get for ductal carcinoma in situ are wire-guided localization excisions for cases of DCIS that are detected by mammography. And some cases might be detected by ultrasound or MRI. When we get wire localization excisions, we should receive a copy of the specimen radiograph and the results of the radiologic studies so that we're better able to gross and sample the specimens and correlate with the imaging findings. The localization excision was guided by MRI. MRI uses vascular uptake, so it's not possible to obtain a specimen image and find the MRI finding. So in those cases, we're obliged to block the entire specimen. Sometimes we receive non-localized excisions for DCIS. This might be in cases where DCIS is palpable. Usually it isn't, but in some cases it is. Or if the surgeon has excised a major lactiferous duct or subareolar tissue for nipple discharge, the surgeon may be anticipating that we'll find a papilloma, but we find DCIS in those specimens. For examples of mastectomy, we obtain cases of simple mastectomy without an axillary dissection. Skin-sparing mastectomy is a mastectomy that includes the nipple and a rim of surrounding skin. Many of these patients will be going on for immediate breast reconstruction surgery. In cases, we have a larger amount of surgical margin to assess. The whole anterior margin is a true margin. Really, we might receive a modified radical mastectomy for DCIS, which includes an axillary dissection, and we should not be seeing radical mastectomies for DCIS, which includes the pectoralis muscle. The checklist under specimen integrity, our options are that we have a single intact specimen where margins can be evaluated, or we might receive an excision where the surgeon has taken margins separately. Ideally, they should be oriented and designated as to where exactly they have come, and we would sample those margins separate from the main excision. Sometimes our specimens might be too fragmented where margins cannot be evaluated. We should be measuring our specimens in 3 dimensions, indicating the individual planes if the specimen has been oriented. We provide a weight in grams, and this gives the clinicians an idea of the volume of tissue which has been excised. Comment on the placement of sutures for orientation and to report on the specific of designated margins. In convention, I think many of us use the long lateral, double deep, short superior for suture placement for orientation. Laterality, right, left, not specified. If the surgeon has not indicated where excision has come from, we should phone and find out. A tumor site is areas where DCIS is identified. So in a mastectomy, we may find it in more than one quadrant, retroareolarly, or involving the nipple in the form of Paget's disease, or DCIS in the subareolar ducts. If we have a conservative excision, we should know where in the breast this has come from. So if it's not specified on the requisition, we might find out from the previous needle core biopsy report or a phone call to find out. I'm just going to review basic specimen handling, and I'll give the example of a needle localization excision, which is most of our cases for DCIS. So in our center, much of breast surgery happens in an operating room in another hospital down about a 5-minute walk away. What happens is the surgeon does the lumpectomy. In this case, the wire is intact. Sutures are placed for orientation, and then places the deep margin into the bottom of this grid container. And we have a rapid porter who waits for the specimen and quickly takes it to the radiology department in the breast imaging area, which is in another building. The porter waits while the specimen has an X-ray, specimen X-ray. The radiologist bracket area of interest with pins, and the porter brings the specimen in the container along with the specimen radiograph to the pathology department. And here we have the accompanying radiograph with the area of radiologic interest marked by the radiologist. Our assistants then ensure that the orientation is correct, that the sutures are in the right place. And the specimen is then measured, weighed, inked with designated inks, and the pins and the needle are kept in place. The specimen is then multi-sected, thinly sectioned in about 3 millimeter sections from medial to lateral, and placed in a large volume of formalin. Our pathology assistants use a little sticky note which they place on the back of the requisition, which includes all of the first information that's obtained before grossing. So here we have weight of the specimen, the measurement in 3 dimensions. If nipple tissue are present, then those are measured. The specific inks that are applied to particular margins, and this has come in a grit container with a radiograph, pins in place, and a wire in place. And as well, the pathology assistants will indicate the time that this inked and open specimen is placed in a large volume of formalin, so that we calculate the cholesgamic time. The students will also make note of when the specimen has been removed from the patient, and we accession the time that it's come into the lab, so we can track the time that it is taken before the specimen has gone into formalin. The cholesgamic time should be under an hour for optimal performance of immunohistochemistry. So we start grossing our specimen. There are a number of objectives that we need to think about. Our first objective is to examine all of the lesions which were identified either clinically or radiographically, so that we're not missing any lesion or perhaps any associated invasive carcinoma as well. Use the specimen X-ray to help orient us. We must look for the core biopsy tract and sample this. When pulled, the entire specimen should be submitted sequentially. And if the specimen is very large, then at least the targeted area, which has been marked by the specimen X-ray and radiologist, should be blocked, along with the margins. The protocol states that if DCIS, LCS, or ADH is identified, all of the fibrous breast tissue be examined. And while this makes sense, I think we've all seen cases like this where we have a focus of ductal carcinoma in situ with a scant amount of specialized intralobular stroma, which appears to be right in the middle of fatty tissue. And so optimally, it's best to look at the whole specimen in order to capture the entire area of DCIS. Our objectives are to sample all grossly detected lesions and to evaluate all of the surgical margins. We have our specimen, which has been oriented, inked, and sectioned thinly. And here the specimen has been photographed to show the previous core biopsy tract at higher power view. You can see a little black mark, which looks rather linear here. For the past 20 years or more, our radiologists, what they inject some fluoroscopy dye along with a small amount of carbon pigment along the core biopsy tract after the tissue cores have been taken. They take a post-film X-ray just to confirm that the needle core biopsy has been taken of the appropriate area. And the carbon pigment acts as a tattoo. So when we have gross specimens, we can find the core tract. This is very useful for DCIS where we may not find a mass lesion, but we can actually grossly see the core biopsy tract. It stays there indefinitely unless the tract is excised. We can also find the core biopsy tract very easily in microscopic vision. So here we have our focus of DCIS with a linear tract of fibrosis with a carbon pigment. And a higher view just to show you the carbon pigment is present in histiocytes and will remain in the breast tissue indefinitely, unless it's excised. Our objectives, again, for a preoperative diagnosis of DCIS is to examine the entire specimen or the entire area of radiologic interest, to document the parameters of DCIS and to exclude associated invasions, to avoid all margins, and to try to determine the extent of disease. So for these reasons that I think all of us find that handling case cases, both grossly and microscopically for DCIS, are amongst the most challenging cases that we encounter. We're having to keep dimensions in mind while evaluating margins and keeping it all of the sections out so that we can really assess and measure the extent of disease. And for cases that are assessed by MRI, we must block the entire specimen. For this list, we are to report the gross extent of DCIS in a particular plane, and as well to try to measure the other dimensions of the lesion. We report the number of blocks with DCIS as a ratio of the number of breast tissue blocks that have been examined. Now, extent of disease is not required for the T classification. However, large areas of DCIS are more likely to be associated with invasive or microinvasive disease. Also, greater extent correlates with the likelihood of residual disease after conservation surgery, or positive margins, and a greater chance of local recurrence. And for this reason, the extent really does influence decisions for radiation therapy and for the need for further surgery. So if only one margin is involved, the surgeon may elect to resize that particular margin, and multiple margins are involved. There's going to have to be a decision whether or not to size the entire biopsy cavity, or perhaps the patient would be better with a completion mastectomy. Larger regions of DCIS often lead to more surgery. DCIS is less important of a predictor of local recurrence when wide surgical margins, so a centimeter or more, are obtained. But this is difficult to achieve in large lesions. So provides this table which correlates the extent of DCIS with various clinical parameters. So smaller lesions, most patients can receive breast conservation surgery, and these tend to be smaller excisions that we can examine in their entirety. In contrast, large areas of DCIS, 4 centimeters or greater, are very difficult at times, especially in women who have small breasts, to manage with breast conservation surgery. And with larger excisions, it may not be practical for us to block the entire specimen. There's a great chance that we encounter an invasive component, and in large areas of DCIS, the surgeons often entertain sentinel lymph node sampling. So DCIS is very difficult to measure. We have to think about it in a 3-dimensional way. We are looking at histology slides in 2 dimensions. So it continues along a branching duct system, branches in 3 dimensions. The growth features and radiographic features often underestimate the extent of disease, and often because our breast specimens, fatty specimens, are often friable and distorted, we may have difficulty figuring out if pieces broken off exactly how extensive the disease is. It's shown with 3 reconstruction studies of mastectomies that some cases of DCIS, especially intermediate to low-grade disease, can be discontinuous with gaps of normal duct, which measure up to 1 centimeter. So we may be able to demonstrate that there's some multifocality if there's a gap of normal breast tissue between 2 blocks with DCIS, but this in fact may be a gap lesion. DCIS really does involve one branch duct system. Again, DCIS at times can be removed in more than one excision, so the surgeon may do their main breast excision, see abnormal breast tissue, or perhaps believe that they've transected the core tract and we get another specimen, and it may be difficult for us to know how these fit together if the surgeon hasn't indicated how they relate to one another, the different specimens. This diagram helps illustrate the problem we have when trying to think about a 3-dimensional structure in 2D. So this shows a duct system extending from the nipple, branching distally. The area marks areas with DCIS within the duct. And depending on where we take our section, extent of DCIS may look different. So we see it as a small single duct, a long duct through here, multiple ducts, or a very long area if it's taken on a tangent. So I have to keep in mind our limitations when we're looking at two-dimensional structures, original sections of 3D structures. It's been done using 3D reconstruction studies on mastectomies that multiplicity is relatively uncommon in DCIS. Usually it involves a single branching duct system, which can be quite extensive as the system measures several centimeters. The more median extent of DCIS in screened populations is between 1.5 and 3 centimeters, so often fairly localized disease. Micropapillary DCIS, however, can be extensive and multicentric. So DCIS is very heterogeneous. Our cases range from localized microscopic disease measuring a couple of millimeters, and we can encounter cases of extensive multi-quadrant disease. So it goes on to describe how we estimate the extent of disease using various methods. The first is when we encounter DCIS in one block only of our excision. Next is serial sequential sampling, non-sequential sampling, and handling DCIS when it's close to opposing margins of our excision. Situation is the easiest to handle. And this is breast wide localization excision that we had. The entire specimen was sequentially blocked, and it was present. There was 20 blocks taken, and a single focus of ductal carcinoma in situ was found in one of 25 blocks to the core biopsy tract. This was the extent of it. There's calcifications and necrosis. At higher view, you can see the calcifications and the carbon pigment marking the previous core biopsy tract. The levels were taken, and the greatest extent was 2 millimeters across the focus of DCIS. So in this case, what one needs to do is to confirm that it's present in one block, cut deeper levels to see the extent of it, and one measures across the entire lesion for the final measurement of extent. With serial sequential sampling, entire lesion is sampled and mapped out. By using this method, we can determine or calculate the extent of DCIS, a diagram of the specimen, or perhaps just using the specimen X-ray and put out exactly where the DCIS, and based on the extent in various planes or using the thickness of slices and of DCIS, we can give an accurate measurement in 3 dimensions of the extent of disease. So going through this method, here we have our localization excision received from the OR. It's been X-rayed, and you can see there's quite a lot. Most of the specimen has the radiologic interest. The specimen is weighed, measured, inked, and serially sectioned. And specimen X-ray is obtained of this lesion, and one would mark on the X-ray or photocopy of the X-ray exactly where the blocks are taken in relationship to the various margins. Another example of a larger needle localization excision, and here the slices have laid out and X-rayed. The radiologist has marked the area of interest in the form of some calcifications. Our assistant has used a photocopy of the X-ray to mark out exactly where the blocks have been taken. And if we find DCIS, say in these 4 blocks and over here, we can, using the different colored inks on the edges of the tissue sections, directly calculate the extent in various planes to give an estimate in 3 dimensions. The non-sequential sampling is described, but this method I don't think many of us use. It doesn't make a lot of intuitive sense. Simply what we do is we count up the number of blocks in our specimen, with DCIS and multiply by 0.4 centimeters to give an estimate of extent. Now, there's no attempt to try to calculate a linear extent of disease, so I think we should probably try to avoid this method. It doesn't really involve a thought of calculating the greatest extent in any one plane of section. Paul goes on to finally describe how we handle a case if DCIS involves or is close to two opposing margins. In a case, we can conclude that the whole area is probably, if we see DCIS in the intervening sections, then we take the distance of the two opposing margins and report that as the greatest extent, if in fact that is the greatest extent of disease. Now, in some cases of high-grade DCIS, we may find a gross lesion in the form of thickening and necrosis, and this can be an estimate of extent, but we should correlate this with the microscopic measurement as well. The diagram summarizes the various methods of determining extent. You have the single slide method where we measure right across the lesion, and this is done when DCIS is present in only one block of the excision. Sequential sampling is really the gold standard if DCIS is present in more than one block, and by plotting out on a diagram or on the specimen X-ray where the individual blocks are taken, we can measure the extent of disease in 3 dimensions and also to calculate the distance to closest margins. Sequential sampling is I think, not to be recommended, and this is whereby we count our blocks with DCIS and multiply by 0.4 centimeters. I guess the margins are also evaluated in other sections. When we have DCIS involving two opposing margins, we measure the distance between the two margins as an estimate of extent of disease. There have been a number of studies that have evaluated different ways to measure DCIS, and I'll just describe this paper, which Dr. Francis O'Malley was the senior author. And this group retrospectively compared serial sequential sampling of 78 breast excisions with DCIS compared to these different methods, measuring the size of calcifications on the specimen X-ray, using this form of non-sequential sampling, which is multiplying the number of blocks with DCIS by 0.3 centimeters, and finally measure the largest extent of DCIS on a single slide. Now, these were not cases that just had DCIS in one block only. And they said all 3 of these alternative methods underestimated the extent compared to serial sequential sampling, especially in cases where there were large areas of DCIS. They recommend that the single slide method should only be used in cases where DCIS is limited to a single slide. And when feasible, the serial sequential sampling method is really the best method to use. Ontologic types, this is fairly straightforward in DCIS. We classify DCIS as either TIS, DCIS, or TIS Paget, and we can use the Paget designation whether we see DCIS in the underlying breast tissue or not. If they're coexisting invasive carcinoma, then we use the stage of the invasive component. Not use this protocol for cases of classic or typical LCIS, where extent and margins are not usually reported. However, we can use it in difficult cases of carcinoma in situ, such as mixed DCIS and LCIS, polemic LCIS, and LCIS with necrosis, as the clinic may choose to treat these lesions like DCIS. So just some pictures. Here we have an example of Mammary Paget disease with the atypical glandular cells extending in a pagetoid fashion into the epidermis. Classic LCIS, we do not use the protocol for this disease. How we can use it in cases of pleomorphic LCIS and in LCIS with necrosis. These include the common architectural patterns that I have listed here. And other patterns, if we see another version of DCIS, we report it as other. So some of these histologic patterns. So needle pattern, which has zonal type necrosis, usually seen with intermediate or high-grade cytology. Form, our typical gland-within-gland pattern. Mammary pattern with these well-defined bulbous micropapillae or bridges. As we see mixed lesions, in this case micropapillary and cribriform growth. Pattern where the DCIS exhibits true vascular cores. And a pattern where diagnosis, especially with low-grade solid pattern, is either carcinoma in situ. In this case, this is a solid pattern of DCIS with polymembranous staining for E-coherent immunohistochemistry. So rare patterns which we sometimes encounter are apocrine, DCIS, neuroendocrine cytology, flatter clinging pattern, solid papillary, secretory, and mucinous DCIS. I'll show you some examples of these. So our apocrine cytology, where there's necrosis and quite pleomorphic cytology. These types of lesions need to be distinguished from versions with less atypia of apocrine atypia. In this case, there's necrosis and mitotic activity and marked architectural atypia as well. DCIS, in this case, this was associated with a neuroendocrine invasive component, a pattern of intermediate grade DCIS, papillary pattern where there's small fibrovascular cores, and sometimes, often the solid papillary pattern is seen with a mixed invasive component. A higher view showing the fibrovascular cores, and this form of DCIS also expresses neuroendocrine markers. The secretory pattern is quite rare, and this had an associated invasive component which looked rather similar in cytology. In this case, the ducts were filled with secretory material and a higher power view. The cytology looks rather like lactational change, active nuclei and vacuolated cytoplasm, but with a much greater atypia and mitotic activity along with an invasive component. And mucinous producing DCIS, in this case, was associated with a mucinous invasive component. The nuclear grade is more prognostically significant than architectural patterns, and we grade these as low, intermediate, and high grade. So for low patterns, this is our classic pattern where there's very monomorphous cytology. The cells are well placed, and one can see cell membranes. The nuclei would be approximately 1.5 times the size of a normal luminal cell. Nuclei are inconspicuous, and the cells maintain polarity around rounded spaces and bulbous micropapillary. And we should see very few mitoses, and usually there's no necrosis. Contrast with intermediate grade DCIS, one can see mitotic activity, a great degree of nuclear pleomorphism, nucleoli, and coarser chromatin pattern. And one may also see necrosis or start to see more necrosis with intermediate grade DCIS. High grade, the cells have lost polarity, there's mitotic activity. In general, the nuclei tend to be greater than 2 times the size of a normal cell. Prominent nucleoli and greater degree of pleomorphism. We sometimes see cases where the grade is mixed. In this case, there's both low and intermediate grade cytology in this form of DCIS. And the protocol gives us this table just summarizing how we grade DCIS. The checklist we tick not present but focal in the form of small foci or single cell necrosis. This is all termed punctate necrosis, or present in the form of central, expansive, zonal, or comedotype necrosis. The presence of necrosis tends to correlate with mammographic calcifications, and the radiologists take note of this because DCIS that presents as calcifications often recurs with calcification. So patients can be followed with mammography in their surgery and treatment. And we distinguish the necrotic debris from secretory material, which can also calcify, but with necrosis we should also see nuclear debris. And an example of DCIS with some single-cell or punctate necrosis in contrast to cometonecrosis. This checklist or options are: margins cannot be assessed, or margins are not involved with DCIS, but we just specify the distance from the closest margins in millimeters and specify which margins are close. And thirdly, margins are involved with DCIS, and again we need to specify which margins are involved, and the protocol has criteria for the extent of involvement, which I'll come to in a minute. We need to think about applying inks very carefully to avoid tracking and penetration into the specimen, and it's best to sample our blocks with radial sections or perpendicular sections so that we can report microscopically the distance of DCIS to the closest margins. The protocol states that a positive margin requires ink directly on DCIS. Negative but close margins, we report this, but we should bear in mind that this does not mean that there isn't DCIS left in the adjacent breast tissue. We know that to be true because there can be gap lesions, and we're examining every micron of section tissue that's excised. So with close margins, there is a greater chance of DCIS remaining in the adjacent breast tissue. So this just shows an example of carcinoma in situ present directly at this inked and cauterized margin. So and that seems to be present focally. In many cases, surgeons will take excision directly down to the muscle fascia. So often the deep margin is not a big concern. So from their operative report, if they've gone as far as chest wall, and so often there's no further breast tissue to take. So if a margin is close along the deep margin, the surgeons are not too this margin. Also, in many cases, the superficial margin will be a skin flap. So the surgeon will undermine the skin as close as possible. So if a margin is close to the superficial or anterior margin, there may not be a lot of breast tissue or very little breast tissue left to take. Where this becomes a worry, though, is with a skin-sparing mastectomy, where a greater amount of breast tissue can be left in these larger skin flaps. So it's important for us to really sample the superficial margin well in the case of a skin-sparing mastectomy. So the protocol gives us some criteria to measure or comment on the extent of positive margin with DCIS. They have said that focal DCIS involvement is when we find DCIS at a margin which is less than 0.1 centimeters in area in one block. In contrast, extensive DCIS is when we find it over an area of 1.5 centimeters or grossly or more, or in 5 or more low power fields or 8 or more blocks. So that does seem quite extensive. And in between cases, we would have to specify exactly the extent of involvement, number of blocks, and over what distance. And that gives the patient an idea of how extensive the disease is and help plan for the subsequent surgery, if any. This example of ductal carcinoma in situ present really close to this blue edge, but in this case there was tracking of ink. You can see there's a cleft here, and the true margin was a couple of millimeters away. So this is, I think, we're all used to seeing is tracking of ink along our friable margins. Here's a case where the margin is here, and so the DCIS was about 1 millimeter away from this margin. Close margins, we should use an eyepiece micrometer to measure. With further margins, I just use my stage micrometer when it's in the right plane. The protocol then goes on to deal with treatment effects following neoadjuvant chemotherapy. With checklist, we tick no known pre-surgical therapy, which is usually the no definite response or probable or definite response to pre-surgical treatment. Situations when our patients with DCIS might have encountered neoadjuvant therapy might be for treatment for contralateral breast cancer, and instantly DCIS was found in the opposite breast and then treated, or a clinical trial setting. Now, the histologic changes to treatment of DCIS are not well described, and the significance to the changes we might see are not really known. Taken some pictures of a case I had a while ago. This was a 44-year-old woman who had locally advanced breast carcinoma for invasive disease. She had a partial response to neoadjuvant chemotherapy, and with invasive tumor present in only one block, but multiple blocks taken of the tumor bed showed large areas of calcification, which at higher view was associated with high-grade DCIS. So I wondered if all this calcification was partially treated DCIS. So I would just describe what we saw. So sampling has been described before in the protocol for invasive breast carcinoma, so I will review it quickly. It really is the same checklist. Ours are no lymph nodes present, sentinel lymph nodes, an axillary dissection, or lymph nodes that we might have encountered in the breast specimen, such as mammary lymph nodes. So a number of situations where we may receive lymph nodes for patients who have a preoperative diagnosis of DCIS. This is in the case of extensive DCIS, where we know that we have a greater chance of encountering invasive carcinoma. If we previously reported the core biopsy as suspicious for invasion or microinvasion, if the imaging or clinical findings is suspicious of an invasive component, which is a stellate mass, which didn't correlate with our diagnosis of DCIS on core, or we get sentinel lymph nodes in patients who are having a planned mastectomy, where if we find invasive disease in the mastectomy, the surgeon cannot go back and do a sentinel node procedure, or in the case of breast reconstruction, where the surgeon will not want to go in and excise any axillary tissue for fear of interfering with the vascular pedicles for the reconstructive surgery. The gross sampling of the lymph nodes, small lymph nodes, 2 to 3 millimeters, these submitted tagged. Large lymph nodes should be thinly sectioned at 2 millimeter slices, and we should not mix lymph nodes from slices from lymph nodes together. They should all be submitted in their own designated cassettes for proper staging or staging. If we have a grossly involved lymph node, then one section of the grossly involved lymph node is sufficient. For microscopy, a single H&E stain section of each lymph node is considered sufficient, and to do additional studies such as levels or immunohistochemistry, we should mention this in our report. Cases, most of the time, if we encounter tumor cells in lymph nodes with a diagnosis of ductal carcinoma in situ, we're going to encounter isolated tumor cells, and the significance of this finding hasn't been well documented. If we find larger nodal deposits, actually, if we find any nodal deposit, we must really think we're missing a case of occult invasive carcinoma. And if our excision isn't blocked completely, then we should probably go back and block the whole specimen. If it's a mastectomy and it has not been x-rayed, x-ray the wet tissue, and perhaps some deeper levels on some blocks that might appear suspicious of invasion should be taken. So we need to really consider if we're missing occult invasion in the specimen. For the checklist, we report the number of sentinel lymph nodes examined, the total number of lymph nodes examined, the number of lymph nodes with macrometastases, the lymph nodes with micrometastases, the number of nodes with ITCs, and the size of the largest metastatic deposit. Report whether or not we see extranodal extension, and this is important. With extranodal extension, there's a greater chance of a recurrence in the axilla, and sometimes the radiation oncologists consider doing a radiation boost in this area. Report how we have evaluated our sentinel nodes. Oh, here we go. We case where the patient has at least one macrometastasis, then we tally up the lymph nodes with macrometastasis and micrometastasis for the N classification, and we should not include lymph nodes with ITCs in this count. And if no lymph nodes have been sampled, we use the X designation for the PN staging. Now, ITCs may be detected by routine histology as well as keratin immunohistochemistry. They should not show evidence of malignant activity, such as proliferation or stromal reaction, which we might see with micrometastasis. The SN designation is used for sentinel lymph nodes and mammary dissection nodes. Example of an isolated tumor cluster measuring less than 0.2 millimeters and micrometastasis. Staging information that we might need to use would be R, the small R for recurrent disease, small y for post-treatment cases. Our staging is simply PTIS DCIS or PTIS Paget. And if there has been a previous needle core biopsy with invasive carcinoma, one would need to incorporate that into the T classification and use the invasive protocol, not the protocol for DCIS. And here's an example where much of the specimen contained intermediate and high-grade DCIS, a small focus of microinvasive carcinoma. With this stain is smooth muscle chain myosin, and you can see that these little nests lack a myoepithelial cell layer, so microinvasive disease. I've listed the number or the myoepithelial markers that we have at our disposal. I think the popular ones that we like, which was the best, are smooth muscle myosin heavy chain and P63. We should bear in mind, though, that myoepithelial cells can have altered expression in the setting of high-grade DCIS and in the center of radial sclerosing lesions. And in the case of high-grade DCIS, we may have cases where we see reduced or absent expression of the smooth muscle myosin heavy chain. We're really expected to be there. Also, this problem has been demonstrated with CD10 and CK5-6. So in difficult cases, we should think about using a panel. Other markers might confirm what we're seeing on the H&E and that there really is a myoepithelial component. P63 and component might be good to use in the panel as well. Protocol suggests that if we have other additional findings, that there's space to mention this. An example that they give is if a core biopsy documented a benign lesion such as fibroadenoma and DCIS is an incidental finding, then we should describe this finding. And an example of fibroadenoma that had quite a large area of intermediate and low-grade DCIS and just a higher power view with a solid pattern and cruciform pattern. Another example of this other finding might be in the case of a papilloma where ductal carcinoma in situ is encountered within the lesion. Others for this field is we encounter peritumoral vascular invasion, which should be rarely seen in the setting of DCIS without obvious invasion. And in this case, rather like the positive sentinel lymph nodes or with sentinel lymph nodes with micrometastases or ITCs, we really need to think, are we missing occult invasive carcinoma? The surgeons want to think about doing a sentinel lymph node biopsy in the setting, even if we don't find invasive disease. So block more tissue, if we haven't blocked the entire specimen. Think about deeper levels. But it's also feasible that if there has been a previous needle core biopsy, there's a possibility of artifactual displacement of atypical cells into the lymphatic spaces, but I think really we have to think, could there be an underlying invasive component? And I had this case where it was a needle localization excision from a young woman. She had extensive high-grade ductal carcinoma in situ, and a couple of blocks there was definitely lymphovascular invasion. Here it is, our power view. So here's the small arterial with tumor lie in this distended lymphatic space. After, and the entire specimen was blocked, and with some deeper levels, microinvasion was identified in this case. The other thing I think to mention in this additional pathologic findings section is the previous core biopsy track. So we should make sure that we identify this and document it. Also, if the surgeon has re-excised the specimen, we should document whether or not the biopsy cavity involves the margin and perhaps represents an incomplete excision. On to ancillary studies. The protocol does deal with reporting of hormone receptors in the case of DCIS. Now, I know that the practice of reporting and performing ER/PR in DCIS varies across the country, and I'll just present what's outlined in the protocol. Specifically, there have been 2 randomized clinical trials which have shown a benefit for patients with DCIS who go on to be treated with tamoxifen in the form of fewer subsequent breast carcinomas. There's a UK, Australia, New Zealand study which showed a reduction of 18% in the untreated group to 14% in the treated group of subsequent breast carcinoma. And BP-B24 showed a similar reduction from 13.4 to 8.2%. There was a smaller benefit for women over the age of 50, but overall there was no survival benefit demonstrated. With a subset analysis of the B24 study, it was shown that the women who had the best benefit were those patients who had ER-positive DCIS, and there was less benefit demonstrated for ER-negative disease. For the number of events in this group was very small. So when are the situations that we might perform ER-IHC for DCIS? It may be required for clinical trial eligibility, and I think the decision whether or not we perform it and report it should be made with the clinicians who will be using the information. So in our setting, we do not perform ER immunohistochemistry as a routine, but we will do so if we're asked to do it, which is hardly ever. There's no data on the association of PR positivity and DCIS. Most cases of DCIS are ER positive. These are intermediate to low-grade DCIS in general, and oftentimes they are uniformly positive. The negative disease is usually high-grade, and the protocol states that we should adhere to the same standards of assessment as we do for invasive breast carcinoma. The protocol provides this table, and you'll notice that there's no threshold for positivity, so we report the presence of immunoreactive cells. If it's diffusely positive, we would state that and call it, and in this case they say positive for ER. If it's just a few cells positive, we should try to quantify it and check for no immunoreactive cells present. So where there's a threshold and we're going to perform it, we should probably comment on the intensity of staining and the % positive cells. There's no guidelines for the number of blocks that we should apply the DCIS on, though, or apply the IHC on DCIS. An example of low-grade DCIS that was strongly and uniformly positive, and in a case of high-grade micropapillary DCIS that was negative in contrast to the benign ducts in the background. On specifications, the checklist includes not identified, present in DCIS, present in the non-neoplastic breast tissue, or present in both. I'm happy that the targeted calcifications have been sampled. If not, we might want to use strategies to identify them, perhaps levels, making sure that the area of interest has been completely blocked. And there are strategies for identifying missing calcifications, such as cutting levels and blocking more tissue, thinking about oxalate crystals. For a case where we had oxalate crystals in the setting of DCIS, usually oxalate is seen in apocrine cysts, but in this case, in a core biopsy with ductal carcinoma in situ. The protocol suggests that we include pertinent clinical information when it's available to us, and this includes the presence or absence of BRCA1 mutations that have been documented, current pregnancy or lactation, previous breast surgeries or biopsies, previous cancer diagnoses and location, pre-treatment, and significant systemic disease that we may see effects of, such as vasculitis. Well, the type of presentation is useful to know whether the lesion was of a palpable mass, discharge, or a specific imaging finding, and we document the previous core biopsy site as well as the type of specimen. So that's it in summary, and I guess we can go on to questions.
I've got a couple of questions here. One of the questions is, what one use when one has an encysted papillary carcinoma? Does one use the DCIS or does one use the invasive?
So that's a good question. The encysted or encapsulated papillary carcinoma is a bit controversial lesion. There's been a lot of reports about to define what this lesion is in the literature. The authorities who regard these as slowly growing, indolent, expansile, invasive carcinomas, and on the other side, some feel that these should be regarded as ductal carcinoma in situ. Most of the time, we're not able to demonstrate a myoepithelial cell layer around the periphery of these, so that's one of the reasons why some think that this is probably an expansile invasive carcinoma. The other reason is that sometimes they can be fairly large, 2 or 3 centimeters, and it's hard to imagine an intact duct expanding to that size and still remaining as an in situ component. There's been some argument that it should be regarded as DCIS because of the presence of type 4 collagen around the lesion. It's not entirely clear whether this is DCIS or invasive carcinoma. In general, it behaves like DCIS. It tends to be very, it's been just like DCIS in the past with a conservation surgery and not without further treatment. And the WHO still classifies this lesion in the DCIS category. So I think, if you're going to use the invasive template, I would put in a comment to say that the form of breast carcinoma is very indolent and typically is managed as ductal carcinoma in situ. Or if you're going to use the in situ template, to put a comment that the underlying nature is controversial. Some authorities recommend these as or believed to be slowly expansile invasive carcinomas, which are generally managed like DCIS. And that's finally, you could bring this to a multidisciplinary meeting and just discuss issues so that everybody understands the type of lesion they're dealing with.
Thank you. I have a personal question. Talk about looking for carbon for the needle core biopsy tract. Do you guys actually tattoo when you're doing the needle core biopsies?
What the radiologists do is they have a little solution that's mixed up in pharmacy, which is some inert carbon or charcoal that's mixed in with fluoroscopy dye, and it's mixed up and given to radiologists in little ampules, and they inject some of this before they move the needle after the core biopsy. It's only done in breast stitching. And it's done, so what it does is that the carbon just spreads along the whole core biopsy tract area, and it's great because we can see it grossly, and we can see it microscopically as well. Also, the surgeons like as well, because if they're doing a lumpectomy and they know they've cut through the carbon tract, they might take a little bit more tissue in that area, especially if their localizing wire has moved a bit. It's another landmark for them. So the radiologists in our center have been using this for more than 20 years. I bet it's used in Scandinavia for FNAs, so there's even greater experience with it. And I don't think that they've encountered any side effects or complications. Sometimes it's a little bit of darkening or tattooing of the skin, just a little tiny dot that looks like a freckle. I've seen probably 2 cases of sarcoidal reaction in response to the carbon pigment from 2 patients who have documented sarcoid disease. Other than that, I think everyone's pretty happy with it, and it really allows us to find the core tract that don't have mass lesions.
Okay, there's the first submitted question is, if there is a core biopsy tract but not a biopsy cavity transected at a margin, is this concerning for incomplete excision?
It depends on whether or not the if the core biopsy had, say it's carcinoma in situ, and you find a localized focus of DCIS, the core tract in the middle of your specimen, but follow the tract to the edge, is probably okay, especially if when the radiologist looks at the specimen X-ray, if the area of interest is right in the middle of the specimen X-ray, then they're probably fine. We have encountered on occasion cases where we haven't been able to find any invasive or in situ carcinoma or whatever it was that was found in the previous core biopsy, but the core tract has gone right to the edge, and we block the whole specimen, nothing is found, and then I think we're pretty certain that the surgeon didn't remove the area of interest, and so that leads to more radiologic workup trying to relocalize the tumor that wasn't excised.
Second submitted question is, in the recent Canadian Association of Pathologists newsletter, it indicated that updates were coming to the CAP breast cancer checklist May 25th. Do you foresee any changes or predict any changes to the DCIS checklist?
Not that I'm aware of, but I haven't been involved in that, so I don't know.
Okay. The third submitted question is, if there is a main lumpectomy and a separate submitted margin, should one give specimen dimensions in the synoptic report, even though this may not be accurate given the separate margins?
And I think so that is a problem, again, when we're trying to measure extent in multiple specimens. I think that would probably be a good reason not to have our surgeons submit margins separately like that. We really don't know exactly how they fit together. So in that situation, the best we could do is give at least a statement to say that our specimen, or the DIS in the main specimen, measures at least so many centimeters. But we probably couldn't be as accurate had we received just one single specimen.
So this is actually from Dr. Odette Boutradros. Terminology of the extent of involvement as focal, minimal, moderate, and extensive is confusing. In the inventory notes of the CAP, it is referred to as unifocal, multifocal, and extensive, which is, opinion, better defined. Do you have any comments on that?
I think it is confusing. I guess they're just general ballpark terms that we should think about. Probably what we should just do is in a comment to try to tell the surgeons exactly how extensive it is, and I guess by giving some measurements, it gives them an idea of how extensively the surgeons are involved or not. But I agree, I think these checklists are getting longer, and yet that's another thing to add to it. Probably we should be, rather than just saying positive or not involved, give some information about just how extensive the margin is involved, and that could be in the form of an explanation with a measurement and number of blocks involved. Okay,
so just getting the one. This is from Dr. Lavithil in Hamilton. Does radiology tattoo LABC so that extent of disease can be determined or to locate the area? I'm not quite sure what LABC is.
I'm not sure. So really it's just to locate the area. they do an ultrasound-guided core, then they could also inject the core. They would also do that, or inject the carbon. What they also do is put a clip in place so that the area can be localized if it's an ultrasound-guided core. But they also do inject the carbon.
I guess, so then, do you radiologists in your center that they don't do sort of several areas to try and dictate the extent, so the pathologist has a better idea at gross examination, or do it just with for the biopsy?
Just go and do the biopsy.
Okay. From Marianne Meshavari-Davis, could you comment on small 3 millimeter low-grade DCIS in a papilloma? Would you use the official DCIS checklist in that scenario?
Yes, I think if you had, I guess in that situation, you would be trying to, differential would be, is it ADH in a papilloma, if it's that limited in extent and low grade. But if it met the criteria for low-grade DCIS in a papilloma, then you use the checklist.
I've got a question here from Doug Melger, actually at Grand River Hospital. What's your approach to processing mastectomy specimens for DCIS?
So I guess at the time when we get mastectomies for DCIS, most of the time it comes in the form of completion mastectomy following a localization excision. So we know that already that there is limited segmental disease. And so in that case, we would sample the biopsy cavity very thoroughly, the adjacent breast tissue, and as well other gross lesions and our usual quadrant blocks. A mastectomy for extensive multicentric DCIS, a skin-sparing mastectomy, then what we have to do is handle it like we do the wire oaks, and section the mastectomy, lay out the slices, get a specimen X-ray, and have the radiologist help us identify where we should be sampling. So there are those cases are a lot of work because it's a lot of tissue with extensive disease, and we're having to think about margins as well as look for small areas of invasion.
Thank you. The second question from Dr. Lassell. If specimen is X-rayed in the container, and if so, does this maintain the anatomy better in margin assessment?
If the best way for the radiologist to assess the specimen and feedback to the surgeon is with 2-view specimen X-ray. So if they do an X-ray and then flip it 90 degrees and X-ray the other margins, and then they can actually let them know whether their lesion is close, so my calcifications are close, and probably give an idea of which margins are close. Now, our radiologists don't do that. They can only do the single view, and so they tell the surgeon, your lesion is in the middle of the specimen, or you're close to a particular margin. They may not be able to tell them exactly which margin, which is very limited information. So the ideal setting is if they do 2-view specimen X-ray.
Okay. This is from Dr. Mohammed Sarif Al-Dian. Importance of intratumoral lymphovascular invasion.
If we see lymphovascular invasion in the setting of just ductal carcinoma in situ, which actually I think is fairly uncommon, but when we see that, I think we have to really worry that we're missing an invasive component. So one would want to make sure that your entire specimen is blocked, and you look carefully for subtle foci of invasion or microinvasion, deeper levels in any suspicious areas, using myoepithelial markers if it's not clear, because we should have a high index of suspicion that there's an invasive component in that setting.
A question from Sudbury from Dr. Wojnarko. Tissue submitted entirely, even in a large specimen, partial mastectomy.
Sorry, say that again?
Is tissue submitted in its entirety, even in a large specimen or a partial mastectomy?
I think it depends on how large is large. We actually have a lot of large breast incisions, 200 and 300 grams, and it's a lot of tissue. So in those cases, much of the time what we do is we block the entire area of radiologic interest, all the surrounding margins, put in a few extra blocks of additional breast tissue and start at that point, and leave the remaining wet tissue in sequence so that if we need to go back, we can block more tissue. That's kind of how we approach it, because a lot of the time we have very, very large breast excisions, and block it all is very labor-intensive for our technical staff. So we make sure that the radiologists bracket the entire area of interest, and we go beyond that to block more tissue beyond the calcification. The ideal way, though, of course, to be complete is to block the entire specimen. I think it depends on your resources and the number of cases like that you get on a regular basis.
Thank you. Another question from Dr. Lavasol, Hamilton. It seems to her that a few tattoos at the periphery of a localized advanced breast cancer pathologists determine the original size of a locally advanced carcinoma. A few tattoos just around the edge of it? I guess so, yeah. I would mean that the radiologist would take this at the periphery of the lesion, maybe bracketing it. Yeah, I think that would probably what would have to happen. Yeah, I think from their point of view, their main objective is preoperative diagnosis. So I guess as long as it wasn't at the expense of missing the lesion in the middle, perhaps trying to get anything that looks suspicious of invasion in their core might be the first objective. What they do is, if they think there's multifocal disease, then certainly they'll do cores of different areas to confirm the extent, and that helps the surgeon plan for the surgery, whether or not conservation surgery can be achieved, or perhaps a mastectomy is the better option. We didn't see if there's any more questions. So this is just a follow-up from Dr. Wijanarko in Sudbury. Submit in MRI large specimen, do we have to submit the entire specimen? You do. Because there's no way to identify where the lesion was. It's not possible to find there is interest by repeating the MRI and the tissue once it's removed from the patient. So I think in the MRI-directed excision, we should block it all. I don't think there's any way around it. Yeah. Another comment coming from Dr. Lavasol. She says, yes, bracket the lesion, not necessarily taking biopsy at each site. That is, just circle the lesion. Yeah. So I'm not aware of people using core biopsy to do that, or that the carbon tracks to do that. But what I think tends to happen is that the lesion gets bracketed by more than one wire. So, 2 or 3 wires can be inserted to try to bracket the entire lesion, and that actually is better for the surgeon to be able to get all the way around the lesion successfully. Question, if you see a tumor embolus in an afferent lymphatic just outside a sentinel lymph node and nothing else, would you just classify it as lymphovascular invasion and then maybe go back in making sure that there isn't an invasive component? How would you handle that scenario? Yeah, I think it would be the same idea as if you were to find a nodal deposit in a node. So what you're saying is you'd see that there's just DCIS present in the breast? Yeah. Yeah, I think it's the same problem, that you shouldn't see lymphovascular spread with in situ disease. So I would be worried that we may have found an invasive component in that case. Yeah. If you were to use the DCIS checklist for pleomorphic lobular carcinoma in situ or lobular carcinoma in situ with necrosis, is there a category, I can't remember, is there a category where you say other rather than the ductal carcinoma in situ, just so that there's no confusion if you're using a checklist with DCIS, but in fact it's not really ductal, it's actually a pleomorphic lobular or lobular carcinoma in situ with necrosis? How do you draw that?
I think that would be wise to at least put in a comment to spell exactly what you're seeing. Certainly for architectural pattern, you could put it there, that it's pleomorphic lobular carcinoma in situ, and then you would, I guess, apply grade, necrosis, margins, and extent the same as you would for DCIS.
I think there's a question coming in. Let me just... I think there's one more question coming in. This is from Dr. Monica Aquent. When measuring the extent of DCIS, for example, a small amount, do you include measurements from the previous biopsy? I haven't. It's probably useful to pull the previous core biopsy and just see if it's more extensive in the core as opposed to the extension. What we're left with is not really knowing how those two specimens relate to one another. But if we have a 2 millimeter focus of high-grade DCIS next to the core tract, the original lesion probably was bigger than 2 millimeters if part of it has been removed by core. I'm not quite sure how we would accurately put those two specimens together. I may have a sort of a follow-up question to that. Do you include the linear extent of DCIS in your needle core biopsies, or doesn't it really matter because it's just determining the more definitive surgery?
Yeah, no, I don't. But I guess if you had a case where you might have very, very little left in your excision, you could pull the case and put in a comment to report the linear extent in that situation. But generally, we don't. No.
Yeah. And another question that's come in is, do you serially section lymph nodes transversely or parallel to the lung axis?
I'm not sure. I think usually it is transversely, I think is what the protocol is that our pathology assistants use.
Okay. I think that's it. There's no more questions. So on behalf of Cancer Care Ontario, the Partnership and Canadian Association of Pathologists, I would really like to thank Dr. Penny Barnes for a truly comprehensive and excellent, informative, and very clear presentation today. This is the last session in the series of the CAP checklist presentations, and we'd welcome your comments and suggestions for ways to ensure that these sessions are informative and relevant to your practice. Include your feedback and suggestions as part of your completed online evaluation. Once the WebEx recording of this presentation becomes available, it will be made available for wide distribution by links posted by Cancer Care Ontario, the Partnership, and the Canadian Association of Pathologists. Access to this recording will be available for your review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for CME credits, and in order to receive those credits for attending or viewing the educational session, you must complete an evaluation form for each session accessed or viewed in its entirety. The web-based survey has been included in the session notices distributed prior to each session. Please note that the CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. The sessions will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. And again, please refer to the session notice for the exact deadline schedule. So on that, thank you once again, Penny, and all the best. Goodbye.
Thank you. Bye-bye.